Please welcome David Rubenstein, President of the Economic Club of Washington, D.C.
Thank you very much, and welcome to our 13th virtual signature event of our 35th season. So now we have three medical experts. Kim Horn, who is Executive Vice President and Group President of Markets outside of California for Kaiser Permanente. She's finishing up her first year in that position, but previously headed the Mid-Atlantic region for Kaiser Permanente. And then we have Ken Samet, who has been from 2008, the President and CEO of MedStar Health System in this region. And then Steve Jones, who has for the last 3 years been the President and CEO of Inova. So why don't we just start, and Kim, I'll start with you. How are the hospitals being inundated today with COVID-19 patients? Are your ICUs at capacity? And how bad is it if you come into the hospital today to get first priority treatment for COVID if you have it?
Yeah, so it really varies across the country, David. It's in terms of the infection rate and hospitalization rate. We just came off from the arguably the largest surge in the country outside of New York in Southern California most recently. And where our ICUs were way past capacity, and as well as our hospitals. And so it was enormously difficult. And it's just remarkable how the healthcare industry and our workers just responded to that. I mean, it was, day in and day out, working incredible shifts and, that sort of thing. So thankfully, knock on wood, we're seeing a little bit of a decline, in the surge that's occurring, particularly in Southern California. But we're seeing really high hospitalization rates still in places like Atlanta, and I would, even in the Mid-Atlantic and Virginia and Maryland in particular. We're not out of the woods yet. So, but it's very interesting how. That the surge has impacted different parts of the country at different times.
Well, in the beginning of the pandemic, there was a shortage apparently of ventilators and PPE. Is that still the case? Do you have the masks you need, the gowns, the other equipment, or is that still a bit of a challenge?
No, I mean, that's, in the very beginning, you're absolutely right. It was all about, first of all, understanding what kinds of masks that were, effective and having ventilators and that sort of thing. So we've got that under control. Now it's staff. That's our biggest issue. And, so many people have been impacted by COVID. We're not able to get travelers, healthcare traveler workers where there's peaks in. So that's a major, issue. And so right now, and not just the surge, taking care of COVID patients, but even as we think about the vaccination, this phase, hopefully the final phase of COVID, preparing for mass vaccinations, having enough staff and, to be able to do that and that's really why, and particularly with my colleagues here, why it's so important that we work together with public health and the private sector and the healthcare industry to really get organized around mass vaccination.
Okay, Ken, in MedStar, are you having do you have enough ICUs, enough equipment to deal with the COVID patients that come in, or the COVID patients coming in going up or going down in terms of their coming into the hospital now?
So I'd say for the region we're in now, thankfully, the last 2 weeks, we've seen a bit of a downturn, which is really good coming out of the Christmas holiday. We did see a surge. We went up at MedStar to about 650 COVID patients across MedStar 2 weeks ago. We're down to about 540 today. So that's really good. And if I tied that 650 back to the spring, when we had that surge, the initial surge, we were at about 725. What's interesting in the region is in the spring, Montgomery and Prince George's County were 50% of all of the COVID hospitalizations in the state of Maryland. That was the epicenter. So for hospitals in our region, combined with the District of Columbia and Northern Virginia, we saw a more significant load of COVID patients. It's been spread across the state differently this time, which has helped in our immediate area. But the big difference right now, and I'd connect to Kim's point on staffing, PPE and ventilators and all of those issues are not the issues for MedStar, Inova, and the big systems here. Staff is the issue. To Kim's point, we're not able to get travelers from across the country, but also we're not canceling elective cases. And elective, and I know we'll all talk about that, is really a big definition. So let's make that non-COVID cases, cancer, cardiac, a host of other cases that got canceled in the spring. That actually let us have more staff internally, but was a really bad decision relative to trying to take care of our patients who needed care. That's not happening today. We're fighting very hard to take care of COVID and non-COVID patients, which stresses staffing all the more.
Okay, Steve, let me ask you a question about Inova. So how is Inova doing in terms of too many patients coming in for COVID-19 treatment? And let me ask you, you're a doctor. If you got COVID 9 months ago and came into your hospital, did you get better treatment then than you're getting now, or better treatment now than you got then because we know more?
Getting unequivocally better treatment at this point. We know a lot more. Even to your question on ventilators, initially we had patients on ventilators that we learned subsequently, probably we across the country, across the world, were using ventilators too early because that was the traditional way that you took care of patients with serious respiratory diseases. At this point, we do almost everything we can to keep patients off of ventilators. So we've got hundreds of extra ventilators around, but it goes to even the pulmonary care and the positioning of the patients. And we now have some therapeutics, both inpatient and outpatient therapeutics. So your care now is exponentially better than it would have been even 9 months ago. And the mortality rates have dropped dramatically as a result of that.
Now, what about the therapeutic that President Trump got when he went to Walter Reed? That seems to be like a miracle drug. Maybe there's some side effects, but it seems like a miracle drug. Is that something that you can readily give people, or is it only experimental still?
Well, it's under an authorization, so not fully approved, but we are using it on a routine basis. We've given that those drugs, there's two, we've given to over 800 patients at this point. We're now giving them even in our emergency departments. So as opposed to being diagnosed and set up a day or two later for the infusions, we're routinely pulling patients right down the hall and giving the infusion right there. So you get the effect immediately. The results are a little bit controversial if you look at the studies of how much their impact is. But from those results and from our own experiences, we believe that we're keeping patients out of the hospital for sure. Not all patients, of course, unfortunately. But importantly, even if we don't keep them out of the hospital, if they eventually end up in, their disease course appears to be less severe than it would have been otherwise. So we're very enthusiastic on these at this point. We'll continue to study them, and that may evolve, but at this point, we're being fairly active in their use.
Okay, so this morning I got my maybe 10th test for COVID, and all 10 have been negative. And the tests are a little bit less painful. They used to put the stick all the way up to your brain. Now, not quite as bad, but let's suppose I turned out positive. Should I rush to a hospital and say, put me in ICU because I turned positive? Or what should somebody do if they have positive rating that comes back from one of these tests?
Unless they're acutely ill, they should stay home and quarantine. And when we say stay home, for some people, they can, of course, distance and quarantine well if they live in a house with multiple people. But keeping distance and not rebreathing air is really critical to that. Only if you really get to the point where you're having breathing or other difficulties should you go to the hospital for evaluation, and not even assume you'd go in. But again, you might have an infusion as opposed to have to be admitted. But importantly, the infusions need to be in the early days. You can't, be 2 weeks in and think that they're going to have any impact.
Okay. Kim, let me ask you this. How do I get vaccinated in this area? I don't have a vaccine. I'm in and the private equity profession doesn't seem to be at the top of the list of people that deserve to get vaccinated first. So how easy is it to get vaccinated? Do you have enough supplies for all the people that show up? And how do you decide who gets it?
Okay, so let's start with the supply, first of all. And every one of our locations across the country, including here, we're approved vaccination sites. And we've been very proactive in identifying based upon the jurisdictions, guidelines of what age, 1A, 1B. But quite frankly, we've given about 29,000 vaccines so far in this region, Kaiser Permanente. And it's just really a fraction of what, the universe of people and the certain guidelines would entail. So, and that's just true across the country. And so, the availability of vaccine supply is critically important, to this. And the second is once we have it, then, given the numbers of people that we need to get through the vaccination is something we really need to work on, I believe, max vaccination sites and strategies. Where that we're being very planful about the number of people that we need to vaccinate, locations, because you got to think about space. You have to have enough for social distancing, as well as, people need to stay around for a while to be observed. And, literally we have millions of people that need to get vaccinated. So no, we don't have enough vaccine. We're optimistic and we're planning as soon as we get it. It's like within, we're scheduling people immediately to, and there's never a vaccine that isn't used or put into an arm, as soon as possible. So a lot more work on logistics, vaccination supplies, and a really huge opportunity in this region to do coordinative efforts, across the region and within jurisdictions to work together and, on these strategies.
Based on what you've heard, if I have a choice of using Pfizer or Moderna, does it make a difference if somebody said, which one do you want, or they're both the same, pretty much?
I would say that there's no difference at all. Just make sure that you get the vaccine. They're both, there's no indication that one's more effective than the other. What we do try to do is to make sure that each, whatever your first vaccine is, that we're consistent, with the second vaccine. And so it's just part of the scheduling logistic challenges that we get people back in and for their subsequent vaccine with the same, either the Moderna or the Pfizer.
Hey, David, can I just jump in for a second? Because I think what's behind your question that certainly is one of the biggest frustrations for all of the citizens, and it is absolutely the biggest issue for Stephen and Kim and me and our colleagues, is it's the lack of understanding a predictable level of supply that we will receive on a weekly basis if we understood the schedule. And that's true for America. And it's about leadership, because if we actually said to the country, this is what we have, this is what the supply line looks like, this is how we'll roll out. After that moment, once we know that number, it's a math equation to then design distribution at the mass level, at hospital levels, and we can work within the guidelines of who can actually get a vaccine. But because there is a false set of expectations fed by a lot of communication and conversation over time on this, people think actually every 58-year-old friend and 65-year-old friend I have can't believe they don't have a vaccine on January the 27th. And it was only December 11th that the first EUA for Pfizer came out, December 18 for Moderna. If you think about that, we were never going to be in that moment unless somehow there were 200 million vaccines coming off the line. So we need a reset. And then we really do need to understand in a predictable way what we, Inova, MedStar, Kaiser, what will we get? And then we can actually work directly with our patients, whether they're in private equity or not, to actually tell them, register, this is when you'll be able to get a vaccine, and this is what you need to do until then, which starts with wearing a mask.
Well, Ken, let me ask you this. Are people calling up and saying they're having a healthcare emergency, they have to get it even if they're not otherwise qualified? Are people coming in with fake IDs about their age? Are people cheating in some ways that is very discernible to you? And all of your healthcare employees, have they been vaccinated yet?
So I would say that overwhelmingly people are trying to do the right thing. There's always examples, and we all see them at times in the news, that someone tried to cheat the system. That's not the overwhelming issue. We are getting tens of thousands of people reaching out, asking how they can get a vaccine. As it relates to MedStar associates, 31,000 associates, 60% they've all been offered. 60% have taken the vaccine at this point. But as my colleagues could talk about, the real important part of that story is the variability that happens with the diversity of our associates, and people of color taking at much lower percentages than our general associate population. That is also playing out true in our region. If you look at the rates in Prince George's County being different than Montgomery County, It's really not a good thing. It's an education, it's a trusted voice issue, and we all have to do the best we can on that.
Hey, Stephen, what about in your organization? Do you have enough supplies, or are people standing in line? Have all your healthcare employees been vaccinated? Have you been vaccinated?
I have been. I'm a practicing physician, so I've been vaccinated on the second day that we had access. All of our employees have had the opportunity. We've had probably about 60% uptake, similar to what Ken just described. We see a disproportionate hesitancy among many members of our Black and Brown communities. Our Inclusion Council took this on before the vaccines even arrived to address very legitimate concerns on vaccine safety and effectiveness. And fortunately, we're seeing that break down, but break down nowhere near as fast as it should.
And now you've been vaccinated. Did you have any side effects?
I had zero. I've certainly spoken with others who have had some side effects, but similarly, when I had my Shingrix shot, which is for shingles, I had a significant reaction. I felt bad for about 36 hours, and then I felt good knowing that for the rest of my life, I was protected. Even for those individuals who have responses to these current vaccines or any that come forward, even if they have those responses, they should feel very good about the fact that they've got 95% protection against one of the most horrific diseases that's come along in our lifetime. So it's absolutely worth it, even if you have the side effects, but most people don't. I tease that. I go through the area where people are waiting the 15 minutes after their vaccine every day. And it's the most boring part of my day because most people are sitting back there simply waiting for when they're told that they can leave the building.
So you're a medical doctor. Tell me the answer to this. Let's suppose I get the first vaccine, but then I just never get around to getting the second one, or I don't get it for a long time. Is that the first vaccine therefore useless at that point?
We don't know the answer to that. There's a lot of hypothesizing going on that topic. We tend to be very diligent at Inova on focusing on the science, and the science indicates that you need both of those doses at the timetable that the studies showed. We may find, again, science evolves, and we may find out differently in the future. We've so far found that 95% of folks do come back in that window. And interestingly, if they don't come back in that window, at least through, again, very short period of time, they don't appear to come back. So about 5% are choosing not to come back. We don't know why, and we'll continue to look into that, but that's unfortunate.
Suppose somebody calls you up, and has this happened, says, I'd like to make a contribution to your something part of your hospital system. Here's some money. Oh, by the way, could I get a vaccine quicker? Does that work?
It absolutely will not work. And I think that the one good thing across the country, I think we've seen extremely few instances of that. And people often ask, well, why can't I get, again, everybody wants to be next. And I say, call my own wife and ask her, because she's not eligible yet. The first time she's eligible and there are doses appropriately available, she'll be in line. But right now, I think we've done a good job as a country of largely avoiding that skipping in line concept. You'll never get completely away from it, but I think we've done a great job across the country.
Okay. Kim, let me ask you, in your case of your hospitals, who pays for all this? So do I just show up and I walk into Kaiser Permanente and say, guess what? I'm a Kaiser Permanente member. I'm 65 or older, or 70 or older, whatever the age is. And then they just stand in line. How do you get in line, and how do you decide who's going to get it and who's actually paying for it?
Well, so first of all, it is free to the public, right? Members of Kaiser Permanente and non-members of Kaiser Permanente. We're approved provider in all locations, and we've, in our case, we take non-members and members, but for our members, we actually do reach out to them. And so, we know their age, their comorbidities, often their occupation. Sometimes they call into us and we put them in a, kind of a standby list, depending upon, how we're, the phasing of vaccination, each one of the jurisdictions. But if they're not coming in or calling, we're reaching out for to get people vaccinating, get them scheduled. But getting back to what Ken had mentioned, the really frustrating thing is, because people, this is a high anxiety. There are some weeks we get 60,000 doses of vaccine. And so we schedule, you have to schedule ahead. And then that next week, you've got people scheduled, and then you find out you don't, you have a fraction of that, dosage. So so it is as soon as we get the vaccine, we've got people in queue, I would call it. And ready because we've got to make sure that it doesn't sit around, that we get as many people vaccinated as possible. So we are keeping a standby list of people who are either calling in or who we know meet the criteria, based upon the phasing in jurisdictions.
Now, in testing, when I've been tested my 10 times, usually people, they want to put something up my nose and so forth. I always like to ask them as a courtesy, how long have you been doing this and what were you trained as? And you get a varying number of answers, and they seem to be doing okay. But who actually is trained to put the needle in your arm? You have to be a nurse to do that, or can you train non-nurses to do that? And should I worry that they're going to put the needle in the wrong place or something?
I think it's important that we address that, David. It's a real good
Okay.
question, because we have lots of people who right now we need in the intensive care unit or in the emergency department, but unfortunately they're in the vaccination centers. And so I would, at least during the current emergency, advocate that we allow other folks, physical therapists, occupational therapists, medical assistants. Those are all totally capable of doing that. And a clarification at a federal and state level, I think, would be helpful to expanding the number of people who could do that.
But is it hard to screw up putting the needle in the arm, or take a lot of training to do that? I don't think I could do it, but how long does it take to get trained to do that?
I think I could teach you in about 3 or 4 minutes.
Yeah, well, you've never seen my physical capabilities. It'd probably take a couple hours, but okay. So
I was going to jump in and say, to Stephen's point, we actually developed a quick simulation training model. It's literally 6 minutes with the introduction, because medical students, nursing students, and ultimately the National Guard tied to big scale up sites. This isn't complex medicine. We just have to get people ready for that, because the staff really does need to be taken care of. They do need to be taking care of the COVID patients and non-COVID patients in the hospitals.
So Ken, let me ask you this. What about the new strains that we're hearing about coming from South Africa, England, Brazil? Do you see evidence in your hospitals yet of a new strain of COVID-19 or whatever we're calling it, or you don't see it yet?
So we see the early signs of that, and we test for that. Not on the we haven't seen the South African piece, but I think it would be silly, as you're hearing from the national leaders and Dr. Fauci, it'd be silly to assume they're not all here in the United States, and they'll have implications for us. I don't think we should go to the panic stage of saying, so don't get a vaccine because they won't be worthwhile. They won't be beneficial. They'll be beneficial from everything we're hearing. We'll find out about the efficacy on that. But even if it somehow took efficacy to 70% from 90, we need to do that. It is far better. But the other thing that is so important about these variants is they transmit quicker, which means we have to do everything possible not to let that happen. That means take vaccines when you can. And it definitely means we have to keep beating this drumbeat. Wear a mask, social distance, be smart. We can control this. And I know this has become a political issue, but it's absolutely not. It's the simplest science that there is. We'll save lives while we're getting to, hopefully, some community immunity. It is so important. And yet, for some reason, still seems to be a debatable point for some people.
Okay. Let me ask a medical question again to Stephen. If I've had COVID-19 and some members of my family have had it, should I get the vaccine, or should I say I don't need it because I already have the relevant antibodies? What should I do?
Current science would say that for at least 90 days, you've got protection. The number of people who've had COVID and then have had COVID again is very low. And to my knowledge, no one has had severe COVID after an initial case of COVID. So there's a lot of protection there. So our recommendation is that people wait, and in that 90-day window, if they're eligible, go ahead and get their COVID vaccination.
And Kim, in all the hospitals that you are involved with around the country, is there an advantage in living in one state versus another state to get treatment or to get the vaccine? Or should I forum shop? Should I say, let's suppose I have 5 different homes, which I don't have, but if I had 5 different homes, can I use one of those homes as the place to go to the right place to get the vaccine? Are people doing that, or is there an advantage to doing that?
So I have heard people, contemplate that. And first thing I would like to say that if you're eligible, and there are lots of different providers of vaccine, that we're really encouraging people to get vaccinated wherever they can if they're eligible. So there are different, interestingly enough, across the country, the allocations are not consistent per capita. And so we're hoping that changes that. So we're finding some places in the country, none of them have enough. So let me just say that there's no place that I'm aware that would say, oh, we've got it all. You don't worry about us. But there is varying degrees of allocation by state. And I think we're all really hopeful now with a more concerted, planful COVID response that the allocation will be predictable, as Ken had said, and then the allocation methodology, will have, take into account, the numbers of people that are eligible and in each of the phases.
So David, I just add though, that question is really important for the economic club members listening in this region, because we obviously have a tri-state area. And as it relates to who can get vaccines, right now we have 3 different sets of rules. So Virginia's in a certain place, DC's in a certain place, and Maryland's in a different place relative to age, relative to other comorbid conditions, and can they be considered? But yet we take care of patients, all 3 of our organizations, who live in all 3 jurisdictions. And so this gets back to the need to ultimately have a federal plan, because it's so hard to tell a patient, for us that lives in Northern Virginia, we can't take care of you yet because it's a jurisdictional issue. The same would be true in reverse for Stephen, of course, for a patient in Maryland. So I'm hoping that we can get that complication out of the way, and then we can prioritize those patients that actually need the limited vaccines we have at the highest level.
Well, if we could do that, that would just alleviate so much of the anxiety and angst and the resources that it's taking within the healthcare system to try to sort that out. We have members and patients in all 3 jurisdictions, and the methodology that we have to use, and it changes, in terms of how we're queuing up people and notify them. This is really, really important. And something, if we don't get at the federal level, I would argue maybe it's something we can do in the region, just given the metropolitan, regional nature of our region.
So Kim, in your organization, since COVID has started, has it cost you a lot of money? Have you made some more money than you thought, or you basically break even on COVID on the overall financial situation because of federal reimbursement or whatever, or you lost money because you couldn't do elective surgery? How do you calibrate what the impact has been on your organization?
Well, I think it's cost all of, the economy, not just the, healthcare. And, but I would say in different parts of the country, it's impacted differently. But overall, I mean, it's been a huge economic drain, on all of our organizations, preparing for the surge in the very beginning, taking care of patients. Ken had mentioned that we had to delay, in the very beginning. We didn't know if we'd have enough beds, and then the transmission of COVID. So we canceled not just elective procedures, I would say those things that could be delayed or kind of put off that were not urgent. And then once we brought it back on, then we had to get enough staff and run, even, at greater capacities. And so and now we're, and then there was the testing. So the testing, cost, and then now we're in the phase of finding enough staff. Well, we're getting the vaccine. We're not paying for the vaccine, but we're paying for the distribution, the actual administration and scheduling and many other kinds of things. So it's been, it's been taxing on the healthcare industry, no doubt about it.
So Stephen, I have all the body parts that I was born with. I don't have any artificial ones that I'm planning to get, but let's suppose I wanted to get an artificial hip because all my friends had them, I want to get one. Is now a bad time to come in and get one? Because I might be afraid that I'm going to get COVID in one of your hospitals. Is there a risk that somebody comes in for elective surgery unrelated to COVID and he or she comes down with COVID because you're not adequately able to protect?
I think it's important. That's a great question, David. That originally, when we saw some of the terrible things that happened in New York and Italy, where there weren't protections, there's no doubt that there was significant transmission of COVID, both to the team members who are providing the care and potentially to other patients. We know now how to prevent transmission of this disease. Ken's already mentioned several of them here with maskings and distancing. They're not rocket science, but the science supports that they protect us. There's a way that we know that. So for example, we've had about 10% of our employees at Inova who have had COVID, which sounds like a big number until you see that the CDC said back in November, some months ago, that 15% of all Americans had COVID. So there's this concern of that the hospital is the place where COVID is. The hospital is the one place in the country that's actually adequately protecting ourselves from COVID. And so you should absolutely get the necessary medical care, none that's unnecessary, of course, but the necessary medical care. And in fact, we saw tragedies across the country that where people withheld care, sometimes because perhaps the industry was forced to hold it back, perhaps because people were afraid. And we know that the number of actual deaths has been higher than the number of COVID deaths in these last 10 months. Well, part of that is unequivocally due to delaying necessary medical care. So we would feel very strongly you are safe, at least as safe in the hospital or healthcare setting as you are anywhere else that you go.
And David, I think if I could just add to Stephen's comment, because I think it's really important because the communities have to see hospitals as safe zones, and it's been proven. So even with Stephen's numbers on the percentage of Inova associates that became positive, similar across the region, inside his hospital, I venture to say, and I know it's true at MedStar, the transmission rate between patient and associate in the hospital is actually less than 1%. Our people that are getting sick or getting positive, they're positive from the community. We're not seeing transmission because, as Stephen said, of all of the protections. Everyone is conscious of creating that safe zone in the hospital. So if you have needed care, you absolutely should be doing that. And I think that's a really important message that nobody should hear differently relative to seeking care when you need it in a physician's office or whatever it might be.
So what's been the impact, Ken, on your organization financially? You've lost money from where you would otherwise be because of COVID?
Yes, significantly. Again, part of our mission to do all the right things and worry about, as Steve and I talked with you about in the Economic Club about back in April, it is the single biggest financial crisis in the history of America's hospitals. And we went all in to do the things that the community expects us to do and needs us to do. To give you some numbers, in our Q4, so in Q2, the spring of 2020, we projected a $300 to $400 million deficit at MedStar. We took a bunch of management interventions on both the expense and revenue side. And let's say for rounding that was a $200 million number in Q4. This is all without CARES and support that comes from the government. When we looked at this fiscal year for us, July 1, and we're obviously now into 2 quarters of that, another $100 million worth of impact from the expenses that Kim talked about to take care of all the issues related to COVID. And we're still seeing, even though we haven't stopped doing non-COVID cases, none of us are back to historical levels for a host of reasons. And so, again, that's a $300 million number before what might come from the government in support. So it's a significant issue.
So, Ken, somebody once said anybody who wants a test can get a test. Is that yet the case? Can anybody get a test today? And if I want a test, what do? I just show up at your hospital and say, give me a test?
Yeah, I don't think testing any longer is the issue. So for MedStar, if you have a symptom, if you're symptomatic, you can show up at our urgent care centers, at our EDs. Obviously, you can go to all the primary care physicians. If you simply want to test, though, there are major drive-through scaled up sites all over the region. Getting a test is not an issue.
Okay, Stephen, I may ask you, if I get positive on my COVID test, which I haven't had yet, I haven't been positive yet, and you say I should quarantine at home if I don't feel so bad, what should I do when I'm quarantining at home? Should I drink a lot of water? Should I drink a lot of Diet Coke? Should I go to McDonald's and get things delivered? Or what should I eat that's going to make me recover more quickly? Anything I can do to help myself recover?
At this point, there's nothing other than just taking the normal good care of yourself and staying away from others in that period of time where you could potentially transmit it, because we still don't understand why so many cases are mild and so many cases are severe or fatal. And so staying away from other people is the only advice I would give you in that window.
Okay, and have you had a vacation since COVID started? And are you planning to have a vacation ever, or when are you going to get your next vacation?
So my wife and I drove to Maine and rented a cabin on the water back in early September. It was a great week for us. I currently am scheduled to go skiing in about 6 weeks. And a lot of that will be, one is I'm vaccinated. 2 will be what happens between now and then. We fortunately are seeing the COVID cases going down pretty significantly, but it's always easy to predict the past, not as easy to predict the future. And so whether I actually go hit the slopes, I haven't bought my ticket yet.
So what's more dangerous, going there with you're being vaccinated, but everybody else might not be, or just skiing? Is that more dangerous for you?
I'm a pretty safe skier. David, there's one thing we haven't talked about I think is worth talking about.
Okay.
On vaccine availability, though, one of the things that hasn't been discussed nationally is the fact that we're throwing away a lot of vaccine in the bottom of the bottles. And I think it's time for us to look seriously at that. You know, our pharmacists have looked at it and have been able to get about 8 to 10% more dose out of the bottles. Right now, we're not allowed to do that, but my understanding it's being looked at that we would potentially be able to do that. You know, that's that you think those drops in the bottom don't matter, but if you can get even 5% more, that's pretty significant on the number of Americans that need to be vaccinated. And that's one that I hope will be taken under consideration as well.
Yeah, I know that it's being looked at and so forth. So do you have you ever talked to Dr. Fauci about this? Do you think he's basically feeling a little bit better today than he was a couple months ago?
He looks like he's doing well. I haven't spoken specifically on that topic with him, but I have had the opportunity to speak to him a couple times during this, and I, as always, appreciate his leadership.
Okay, so I think we're out of our time, and I wanted to say to all of our guests, Kim and Stephen and Ken, thank you very much for giving us this information. I assume if anybody has any health questions, they should go to one of your 3 organizations and no other organization. Is that right?
Exactly.
Okay.
Exactly.
Thank you all. Thanks very much for participating.
Thank you.
Bye, everybody.